The impetus for this real world analysis was that the VIALE-A trial was done at some premier medical institutions. It was done under a protocol where there were very selective inclusion and exclusion criteria. And as with any clinical trial, there's so many eyes watching a patient at any given standpoint from their therapy onwards. But a lot of times when these therapies go out into the real world and they change hands to other practitioners and other physicians in the community, their outcomes don't match the center's reported results. And so our motivation behind doing this was to see, were the results that we're seeing now for upfront AML therapy in unfit patients, were they the same as what was reported in the VIALE-A trial? So this COTA database is a very large database of all cancer patients, and they had about 3,000 AML patients in there. So we took the ones that were elderly or unfit, and they were diagnosed after 2019 when there was a practice change with the addition of venetoclax-based therapies up front. And with that, there were about 100 patients that made that cutoff. And a majority of them were treated with an HMA backbone, so either venetoclax with azacitidine or venetoclax with decitabine. And there was a handful of patients that had venetoclax and low-dose cytarabine. So what we did was we looked at their overall response. But again, looking at the criteria for response that we use for clinical trials is much more detailed, taking into account blood counts and all that at the time of response. So we just made a more broad clinical response called real world overall response that included partial remission, progression, and complete remission, and went with the toxicity in those patients and the responses that came with that handful of community treated patients. What we found was that there was just like in any of these upfront AML trials, a high percentage of them were high risk. About 63% had some form of adverse ELN criteria. A majority of them were based in the community. So 95% of patients were treated in the community. But also what we found was that there was quite a bit of missing data. So it was hard to put patients into distinct groups because not everyone had ELN criteria reported. Not everyone had response reported. And the other thing was, interestingly, there were no patients that had any treatment-related AML in this database. And I think that is more of a reporting issue than it is that the 100 patients didn't have treatment-related AML. So we do recognize that there were a couple of fallbacks to the data, but when you look at the aggregate, the median survival with the patients that were treated with a cytarabine was about 6.5 months, and the median overall survival with ven-HMA was between 11 and 13 months, which is pretty much what's reported in the outcomes of VIALE-A and VIALE-C. And the overall response rates were a little bit lower. It was around 55 to 57% in the ven-HMA group, and probably around 33% in the ven low-dose cytarabine group. But again, I don't think that's any statistical significance, just because the ven low-dose cytarabine group was very small. So it really, our conclusion is that it was slightly lower. The response rates were slightly lower than what was reported in VIALE-A and C, but the overall survival was about the same. And the other thing that was very striking was that about a third of patients stopped therapy because of toxicity. And the toxicity in these studies were mostly myelosuppression or pancytopenia. And I think as we use venetoclax more and more, we're seeing that myelosuppression is one of the biggest issues and limits long-term dosing for this elderly unfit population.